All right, good afternoon, good evening, everyone. So we are here opening the concurrent session called Validation and Algorithms, Getting the Present and Future Right. Welcome to the session. I'm Vera Ehrenstein of Aarhus University in Denmark, moderating today with Susanne Guthan Perez from RTI Health Solutions. We're happy to see you here. We would like to announce some ground rules for the presentations. So we have 10 minutes plus 1 to 2 minutes for questions for each presentation. We have later in the session 2 presentations by the same author. We will combine the Q&A for those 2 sessions for the efficiency reasons. When you're not speaking, kindly turn off your microphone and camera. And if you have questions during the presentation, please write them in the chat and the moderator will read them after the presentation. So with that, I would like to announce our first speaker. We will hear from Sasha Dublin about the validity of electronic health records based measures for COVID-19 hospitalization and severe outcomes. So welcome.
Thank you. First, I just want to confirm that you can see my screen with my slides.
We can.
And hear me properly. Okay, great. Thank you for the opportunity to present our work on the validity of EHR-based measures for COVID hospitalization and severe outcomes. Our study was funded by the Garfield Memorial Fund, and here are our disclosures. So for some background, the coronavirus SARS-CoV-2, which I'll refer to as COVID-19, has obviously caused enormous morbidity and mortality worldwide. And electronic health records are often used to study risk factors for COVID-19 infection and for progression to severe disease, including studies of medications as exposures and risk factors. But so far, very few studies have examined the accuracy of COVID-19 related outcomes measured using electronic health data, although looking at the agenda for today, it sounds like that will be a big theme today, and so many studies are in progress. Our objective in this work was as part of a larger study to examine the accuracy of measures for COVID-19 outcomes as defined from electronic health records data, including measures of COVID-19 hospitalization, intensive care unit admission, and receipt of invasive mechanical ventilation, which for brevity, I'll be referring to just as ventilation. We carried out a retrospective cohort study looking at COVID infections and outcomes between the period of March 1st to September 30th, 2020. And this was set within Kaiser Permanente, which is a US healthcare system that provides its members with both healthcare and insurance coverage. And what that means is that we kind of uniquely combine data that are similar to what you see in electronic medical records, but also a lot of the features of claims data, such as complete or near complete capture of outcomes. And 3 of the Kaiser regions participated. Together, these 3 regions serve about 2 million active patients at any given time. We limited our study to people 18 and over. We required at least 6 months of prior Kaiser enrollment. And for certain analyses that I'll show you, the ones where we focused on EHR data for both diagnoses and labs, those analyses were limited to the people who had a single COVID-19 hospitalization. I'd like to start by defining our EHR-based measures and starting off with hospitalization. So we define COVID-19 hospitalization from our data as either a hospitalization where there was a diagnosis code for COVID-19 assigned, or a hospitalization with a nearby positive PCR test, polymerase chain reaction. And we specifically focused on the window that began 28 days prior to the admission date, any tests that happened during the hospitalization, and up to 3 days after. At certain points in the pandemic in our region, there were long delays in test results coming back. So a test ordered during the hospitalization might have come back as late as a few days after the patient was actually discharged. These are the diagnosis codes that we used for COVID-19 infection. When we defined intensive care, we focused on facility revenue codes. And when we defined ventilation, there were a huge array of procedure codes of different types. And also we used the hospitalization diagnosis related group codes. A big part of this study was the use of manual medical record review because we have pretty ready access to our members' records. We can open them up in our Epic EMR. And so we were able to review hospital records, including clinical notes, laboratory results, and other kinds of information documented in the hospital stay. And we focused on 3 groups of hospitalizations because we felt they would be the highest yield. We looked at ones that had a code for both ICU care and ventilation. We looked at those who had a code for only ICU but not ventilation, thinking we might find some misclassification of ventilation status. And then we were interested in the group that had a very prolonged hospital stay, 14 days or longer, but didn't actually have an ICU code, thinking those could be cases that there might be some missed ICU stays coded improperly. So to define our gold standard, we have 2 types of gold standards. One is we did, in some cases, just look at EHR diagnoses and compare them to a gold standard being a lab result in the EHR, focusing on PCR tests again. And we did actually have access to a steady stream of lab data from outside institutions because Epic has a Care Everywhere feature that allows labs from other hospitals to flow into the Kaiser Epic instance. And then for all 3 outcomes, a big part of the study, as I mentioned, was medical record review. And then in those cases, we considered the medical record evidence to be the gold standard. So for analyses, we did 2 kinds of analyses. We compared the PCR test results to the diagnoses, in which case we calculated a PPV, positive predictive value, which we defined as the proportion of hospitalizations that had a COVID-19 diagnosis code that also had a positive PCR test. And then secondly, we were able to estimate sensitivity by asking, among hospitalizations with the gold standard, which was a positive PCR test, how many had also a COVID-19 diagnosis code. Then when we did analyses of chart review data, we could only do PPV because we had sampled based on their outcome status. And we calculated the PPV for each of the 3 outcomes, the hospitalization, ICU care, and ventilation. And in that case, again, the chart review was the gold standard. And then we calculated Klopper-Pearson 95% confidence intervals. So here are some results. To give you some context, there were a little over 1 million eligible individuals during this period, followed from March through September, during which time there were about 8,000 with any COVID infection, about 1,200 with at least 1 hospitalization, of whom the vast majority had only a single hospitalization. There were 453 with codes for intensive care and 207 with codes for ventilation. So this table shows results of comparing the EHR data for labs with the EHR data for hospitalization. So if you focus on that first column, the first column says, here are all the ones with a diagnosis code associated with the hospitalization. There were 1112. Of them, 908 had a positive PCR test, confirming that they were true cases. And this yields a positive predictive value of 82%. And here's the confidence interval. If you look at the top row, that's all the cases with a positive PCR test associated in that time sequence I showed you with the hospitalization. There were 957 with a positive PCR test, of whom 908 also had a diagnosis code, yielding a sensitivity estimate of 95%. So very high sensitivity with a confidence interval 93 to 96%. We reviewed a total of 76 charts across the 3 categories I showed you that we believed had a COVID-19 hospitalization based on our definition. And of those, we were able to confirm that 73 had COVID-19 and the other 3 were false positives. So that gave us a PPV, in fact, of 96% with a 95% confidence interval as shown. And we feel like this is actually more accurate, we would rely on this more heavily than the 82% because we were able to find in those charts comments about outside test results or other ways of confirming COVID-19 that weren't coming through into our system as positive results. Among charts with ventilation codes, all of them were confirmed as having undergone ventilation for a PPV of 100% and a confidence interval from 86 to 100. And then of those with codes for intensive care who lacked a ventilation code, we only found 1 where there was actually evidence of ventilation. So that gave us a suggestion that sensitivity was probably very good for the ventilation codes. But a challenge we ran into that was unexpected was it was actually very difficult to determine from manual review of records whether a patient had truly been admitted to an ICU, because what we found was that our patients received a lot of different kinds of intensive services, things like use of pressors or mechanical ventilation or intensive nursing care, but they happened in lots of different hospital units with all kinds of different names. And you actually couldn't really dichotomize yes ICU, no ICU from the notes and the chart record. So in summary, we believe from our data that EHR data have high accuracy for identifying COVID-19 hospitalization and ventilation, but we didn't feel able to actually calculate a formal PPV for intensive care. To put it in the context of prior studies, other studies have reported very high PPV for COVID-19 hospitalization, but they've reported really disparate results for sensitivity, with one study reporting as low as 49%, and ours is more in accord with the second study that showed a high sensitivity. Of the past studies that have looked at these topics, only one has actually reviewed medical records manually, and 2 of the 3 used data from quite early in the pandemic when COVID testing was very hard to access. And to our knowledge, so far, no published studies have looked at the accuracy for intensive care or ventilation as measured from the EHR in the context of COVID specifically. Strengths of our study include that it was multi-site, including multiple regions, and within each region, many different hospitals, including non-Kaiser hospitals where our members receive care. We included data as late as September 2020, and we conducted a medical record review. But our study has limitations. We could only afford to do a small number of medical record reviews, and thus we could not really accurately estimate sensitivity. Our data don't include the winter surge, and there could be selection bias, as with any COVID study, in who received testing. Although in our system, we've been testing all hospitalized patients since early in March 2020. So our conclusion is that EHR data appear highly accurate for COVID-19 hospitalization and for ventilation, but we didn't feel able to calculate a simple PPV for ICU care and recommend that it may be more effective to focus on studying specific therapies provided to people instead of trying to create a binary ICU yes/no variable. And we very strongly recommend ongoing efforts at validation accompanying drug disease association studies as the pandemic continues. And I'd like to thank the very large team that made this work possible. Thank you. Happy to take any questions.
Thank you very much, Sasha. Very relevant studies. We have all seen examples of bad, fast done COVID research on non-vetted data sources. We can probably all give a couple of examples from recent time. I don't have any questions in the chat. I would suggest that since there were no questions in the chat, maybe everybody can turn on their mics and cameras and try to ask questions in person. Susanna?
Thank you, Sasha, for this great presentation. I was very positively surprised by this high positive predictive value, especially in the context that your study period includes wave 1. And certainly in many countries, and I don't know what the situation was in the Kaiser's system, PCR tests were not available for everyone. Could you comment on the availability of the PCR tests? Was it widely available to anybody who was severe enough to get hospitalized, or?
Thank you. I'm trying to think back. I actually did the chart reviews at Washington myself, and I think the issue was that we had lots of hospitalizations in months other than March. Mm-hmm. And by April, I think we did have ready access to PCR tests. You know, the University of Washington in Seattle was an incredible leader in pioneering and developing its own PCR tests, and the entire region was relying on the University of Washington. And I can't remember exactly when that happened, but I think that, you know, certainly every 2 or 3 weeks, the criteria were changing, but our absolute #1 priority was testing hospitalized patients with respiratory symptoms. So they would have had #1 access to the University of Washington testing. And my impression from reviewing ours is that the overwhelming majority had a positive PCR test in the hospital stay, and that I didn't have any cases, certainly at Washington, that were sort of probable based on symptoms.
Mm-hmm. Thank you.
Okay. Thank you for letting me know that the questions will be coming in the Q&A box. So there's a question from the audience. What is the percentage of COVID diagnosis with the B codes? I think you showed some ICD-10 codes. So the question.
Yeah,
What is the
That is a
proportion?
great question. I don't have it at my fingertips, but I can get it. But the UO 7.1 was really the overwhelming diagnosis at our site, as it has been other places. And I can find that information out.
Sasha, I'm just wondering, we're writing a manuscript on validation studies and describing some of the challenges and chart review process. And one of the questions that comes up all the time, how do you determine the number of charts that is enough to review, to get a result that it would be, I guess, precise enough, or I understand that it all has to do with finances and with time expenditure, but what were you guided by when you selected those 76 charts to review, and what made you say, okay, that's enough for our purposes?
Yeah, that's a really fantastic question. So I think there are certainly situations in my life where I've tried to calculate a PPV of how many charts do I have to do if I had a PPV of 80% and I want relatively tight confidence intervals, how many charts do I need to do? In this case, you know, we started out thinking of this not as something we necessarily wanted to publish, but we wanted to define what will our severe outcome variable be. And we had a feeling that ICU was going to be too squishy. We actually thought it would be because of clinical judgment of who goes to the ICU in different periods of time. And so this was really for us so that we would have confidence and trust in our data. And we thought it was reasonable for each site to do about 25 charts total, given that probably we would be having people doing them over like Christmas break, literally. Mm-hmm. And so it was sort of what the collaboration could support. But I would really encourage people to put in funding for at least sort of 25 to 50 charts for any outcome you care about if you possibly can, because you know, validations don't necessarily port easily over time and over sites, and you need to know your own data.
Great. Thank you for sharing that. There is another question from the audience. Were you able to distinguish hospitalization due to COVID from hospitalization with COVID?
That's another really good question. We didn't attempt to distinguish it formally. We felt that that was, we had a lot of MDs, including an MD who was a hospitalist on the project. And we all felt like in the hospital, it's actually really hard for us to even tell sometimes. But I can tell you from the 25 charts that I reviewed personally, it was those interesting ones that had a really long length of stay that turned out to be like older folks, often with dementia, often from skilled nursing or assisted living, who were hospitalized for something else, incidentally found to have COVID, and then couldn't go back to their facility because they were COVID positive. And so most of the people in the ICU or on ventilation were definitely because of COVID. And then I think some of the others were incidentally detected, less so in the early months when we weren't routinely testing all admissions.
Is there a way to tell that from where diagnosis is recorded?
I wouldn't trust it. Okay. Even if you could make up an algorithm. The issue is trying to decide if COVID is causing the primary symptoms, keeping them in the hospital, which again, even for the hospitalist treating them, is sometimes not an easy call.
Very good point, I think, in a lot of data.
A lot of these people may have CHF, COPD, underlying, you know, respiratory illness, and trying to decide which is truly causing their oxygen need is not going to be an easy task.
Thank you so much. Let me see if there are any raised hands. I don't see any raised hands. I don't see any questions in the chat box or in the Q&A box. So Sasha, thank you very much for this very relevant and interesting presentation.
Thank you.
So our next speaker is Ajit Londe from the Center of Observational Research at Amgen, who will be talking about the death documentation lag in COVID-19. Electronic health records suggest caution in near real-time analysis. Over to you.
Thanks, Susanna. Let me just share the screen. So hi, everyone. My name is Adit Monde, and today I'll be discussing how a lag in death documentation in a commonly used COVID-19 EHR database presents a cautionary tale about performing near real-time analysis. Let me just do a screen check. Are you seeing my screen or no?
Yes, perfectly well. Thank you.
Okay, good. Always have to check. To start, I'm going to orient you to the study our team was working on. We were trying to evaluate the natural history of disease of COVID-19 using near real-time EHR data. First, but ultimately we actually identified a real challenge in that goal, that there was a completeness issue of mortality data. So let me orient you to the data source that we utilized here. This is the Optum COVID-19 EHR database that we utilized for the study. And just to orient you to what this data source is about, it includes records from the Optum EHR network and provides demographics, age, gender, race, ethnicity, census division, and medications prescribed and administered, lab results, vital signs, and other observable measurements. We also get clinical diagnoses and procedures and death events at a month level. For inclusion into this database, patients were required to have a clinical encounter related to COVID-19. Either it's a clinical diagnosis, like some of the codes that we saw in the previous discussion, U codes, B codes, et cetera, or they had a lab test. So we received this database every 2 to 4 weeks, and that was a real benefit here, that it was near real time. In getting that data, we did notice that it is near real time, but the data quantity decreased roughly 3 days before the release date of each of the successive releases. So we made sure to constrain our analyses to not use the most bleeding edge data from the data source. And as you can imagine, as this was a new data product from Optum with a rapidly changing type of environment with COVID-19, there were several rounds of cleaning and standardization of this data source from the start of when we first got it in early 2020 all the way to the end of 2020. And we selected the September 2nd, 2020 data release for our study. Oops. And so we worked on 2 different kinds of analyses here, where we wanted to take a look at what was the completeness of death data in our data set that we were selecting for our study versus the most recent data that we had available to us, which was January 6, 2021. And so across both of these data source releases, we studied adults hospitalized with COVID-19 between January and August 2020. And in doing so, we split these patients up into 3 different time periods: January to April, May to June, and July to August. And so from our analysis, we saw that there were 2 different trajectories that these patients took between the 2 data releases. In the early time period, January to April, there's a death percentage of 16%. In the second time period, May to June, that was 10%, and July to August, 7% in our targeted database version of September 2nd, 2020. And then when we did the same analysis in the second data source, the January 6, 2021 data source, we didn't see the same trajectory. We didn't see a sharp decrease in the death percentage in each of these populations consistently. There's actually an increase in periods 2 to 3 from 10% to 10.6%. And so this started to cast some doubts that we had about the validity of utilizing this September 2nd, 2020 data and using all of the data available to the end of the data base of September 2020. So we took that kind of approach and looked at multiple database versions. We looked at successive versions in September, October, and November. And we applied the same kind of framework of let's use a cohort of adults hospitalized with COVID-19, split them into 3 different static time periods, as I showed before, and take a look and see how do they compare to the most recent data available at the time, which was January 6, 2021. So we essentially used January 6, 2021 as a reference standard. It's not a gold standard by any means, and it doesn't necessarily mean that it has all of the available death dates, but just to kind of draw a line in the sand and do some comparison of death completeness, we utilized January 6, 2021. And so the next 2 slides are the results of that second analysis, and I'm going to show a couple of plots here. So this plot is showing the percentage of deaths missed by successive data releases and the weeks of lag. So if we look at September 2nd, 2020 data, the database release, and we compare that to the reference standard of January 6, 2021, these are the weeks from the end of the September 2nd data set. So from 10 weeks out all the way to 1 week out. And on the y-axis, this is the percentage of deaths missed if we were to compare the deaths in our September 2nd, 2020 data set against January 6, 2021. And you see that early on, or further out rather, 10 weeks out, the amount of missingness is fairly minimal, but as you start to go throughout the weeks, in the 8 weeks out all the way to 5 weeks out, you are seeing an increase in missingness. There are some blips here we did notice in some of these successive weeks. Those are some data quality improvements and issues that are introduced with this near real-time data. But ultimately, we do see a sharp increase in missingness of death events, particularly when you get to 2 weeks out and 1 week out, where you see more than 40% death dates missing, up to nearly 80%. If we do the same with successive releases with September 16, 2020, it's a little bit more stable from 10 weeks out to 7 weeks out, in which we have a fairly minimal amount of missingness. But that does increase in the middle weeks here from 6 weeks out to maybe 3 weeks out, before again rising sharply to the point where nearly 100% of the death events were actually missing in this particular database release compared to January 6, 2021. And then if we look at October 14th, we see a fairly similar pattern. There's some areas of stability here in weeks 10 through 7 weeks from prior to its end of data. And then it starts to increase in weeks 5 and 4 out before increasing significantly in the 3 weeks immediately prior to the end of this particular database. And then lastly, November 11th follows a similar pattern, where it really accelerates here in the last 3 weeks prior to the end of data. The missingness is quite large. So from running through these analyses of taking successive data releases, comparing them against a more recent data source version from January 6, 2021, we saw that as you get closer to the end of each data set, this idea of near real-time data, although very alluring because we need to use it for staying on top of COVID-19 and studying it, we do see that the missingness and death information does make any sort of analyses regarding COVID-19, for instance, in which you need death as an endpoint, particularly troublesome, especially with the last 3 weeks prior to the database date. We did seem to come up with a little bit of an algorithm or a workaround for this, in which we are effectively balancing the need for recency against completeness. And so we ended up selecting 6 weeks as a cutoff. So when we did actually run this study with more recent data this year and submit it as a manuscript, we utilized 6 weeks out from the end of the database as a cut point, and making sure that we are capturing as many of the death events that we feel we can, but still keeping it fairly recent to the current date. So the conclusions we drew, that we drew from this analysis, I think it's important to always evaluate data lag in new data sources. Anytime you bring in a new data source, you should give it a little bit of runway to allow for these types of time series analyses on various endpoints to see if the near real-time nature of that data source may be actually counterproductive. And maybe you should use some sort of algorithm like weighting, or not, maybe constraining the amount of data that you're using. Lag time could influence other data elements beyond mortality. We just focused on mortality here, but certainly you might want to look at other endpoints of interest. And you should always use caution when drawing conclusions from the end of these kinds of near real-time data. And I think that's an important lesson, especially with studying COVID-19. So I'd like to acknowledge patients, healthcare professionals. We also worked quite a bit with some collaborators at Takeda and BMS throughout the last year and a half on some COVID-19 research. Optum for partnership with the data and exploring it and getting better at using it. And then Amgen as our study sponsor and funder. I'd like to acknowledge my co-authors, particularly Corinne Brooks, who was the lead and developer for this study. And our disclosures about funding and stock via Amgen are here. So thank you, everybody. Very nice to be part of this discussion.
Thank you very much, Ajit, for this thorough presentation. Certainly, we're always struggling with fatal events, and I'm sure we're going to learn a lot through the COVID-19 research. I see that, Sasha, you have already placed a question in the chat. Feel free to unmute and make it directly.
Sure, thank you. So first, thank you for a wonderful presentation. This is just so interesting and exciting to see, and a very good cautionary tale. I always find myself trying to ask, like, who entered that piece of information into the database? How did it get there? Do you have any sense of the workflow by which death got into these records? And just remind us, I think you're using actual electronic medical records. These are all hospitalized deaths that happen in the hospital. I'm curious why it would take so long for someone to note that a patient had died, since obviously in real time the care ceases and they're marked as gone or discharged from the hospital. Thank you.
Yeah, it's a great question, and certainly one we struggled with as we started seeing these issues. I think typically this particular data product from Optum, we do receive it as an EHR data source quarterly, and so there is time for things to catch up. That lag is no longer a problem. But as you start to bring it in every 2 weeks or so, the inherent kind of challenges that they have of piping in death events from their Optum EHR network, processing it, applying different de-identification rules, and all kinds of extra pieces that are needed to finally get it into a licensable product that complies with all of the privacy laws and so forth. I think there's a lot of overhead for getting that process done. And so ultimately, it does take some time for some of these death events to actually process through. And because of the near real-time nature, we want near real-time, but this particular process that Optum has for getting these death events just simply isn't fast enough to get those across. I think it's a great question to dive into further. And I think that certainly folks from Optum can probably speak more about it than I can, but sort of from the end user perspective of why are these deaths taking so long to come through, I think it's just, there needs to be some catch up on Optum's side to be able to get them across. And as we start to use more sort of real-time data and start to take a pause and use data that's a little more baked, we don't see that issue as much, of course.
Thank you. We have a question from an attendee. I'm going to allow you, I just marked that you can talk. Dan Mines, please.
This is Dan. I actually don't have a question. I must have hit the button by accident.
Okay, then we have another raised hand among the panelists, but for some reason I cannot. Vera, yes,
that's me. Yeah, thank you, Ajit, for the very relevant presentation. So, are you saying that this may be an issue? This delayed death information is an issue for the Optum database, because I know I work with Danish data and we can see almost in real time online the information about COVID-related deaths. You work with, I know Amgen works with lots of different databases. How does that compare with some other databases that you're familiar with?
So it certainly depends on the database. And I think with other countries' data sources and the way that the healthcare systems are set up, it certainly makes it easier for real-time data to come through. With the United States, with our healthcare system model and the way that these data are collected and sold, there is that extra overhead in place. So I think it is very dependent upon the data source that you're selecting. The statement that we're making that you should use caution with this near real-time data, it doesn't mean that every data source is going to have this issue. It just means that there are certain data sources where, don't be too much in a rush to make use of it simply because it gives you that bleeding edge view. It might be a good idea to give it a couple of versions to then do some comparisons and see, is the version that I received in January, is it complete with regards to different endpoints? Or does it seem like it needs more time in the oven before it's actually complete? So I think the short answer is it just depends on the data source, but I think working with the collector, the vendor of it very closely, and then also taking on your own analyses of it is a good way to ensure that you're using the most complete data.
Thank you very much. I think we don't have any more time for questions. So thank you very much, Ajit, for the great presentation.
Thank you all.
It's my pleasure now to introduce our next speaker. We have Angel Wong from the London School of Hygiene and Tropical Medicine. Angel's talk is titled Shifting the Traditional Model of Analysis Downloaded Electronic Health Records to the Novell Open Source Analytics Open Safely platform. Welcome, Angel.
Thank you. Can you see the slides?
We can.
Okay.
They're now in the presenter mode. Yeah.
This one? Full slides or just present?
You're in the presenter mode. I think.
Okay. Right. Yeah. Is it okay?
Now it's good.
Thank you. So hello, everyone. I'm Angel Wong from the London School of Hygiene and Tropical Medicine. So today I'm going to present you the Open Safely platform and compare it with the traditional model of analyzing electronic health records. So this is the disclosure of the presentation. All of the Open Safely work is public funded. And here comes the content of this presentation. I will firstly introduce you the UK health data, and then moving on to introduce you the traditional model using clinical practice research data link as the example. And then I will introduce you how the Open Safely work, and then finally compare the traditional model and Open Safely platform. So in the UK, the primary care data are usually stored or documented using different softwares. For example, System 1, EMIS, and Vision. And in Open Safely, we use the data from System 1 managed by the TPP and the EMIS software as well. And they actually already cover over 90% of the English population. But then in contrast, the clinical practice research data link, which is a very popular data source in the UK, use the data from EMIS and Vision. And similar to Open Safely, they contains a lot of linked data sets for further data analysis. So I know there are different settings in different countries, but then today I'm going to use a clinical practice research data link at RSHTM as the illustration for using the traditional model. I'm really happy for you to share your experience using other data sources in the Q&A session as well. So first of all, we developed the protocol for research data governance process, and then for the ethics for the approval. And after we get the approval, the abstract of the protocol are usually published in the CPRD website. And then for data retrieval, we usually have two different ways to retrieve the data. The first way is usually there are some nominated fault holders going to the online platform to retrieve the data. The other method is, for example, at the London School of Hygiene and Tropical Medicine, we requested some FLAC files to store in an encrypted secure server. And if you want to do a specific project, you can just retrieve the data using those FLAC files directly. And then afterwards, we develop some code list. Normally, we have 2 reviewers to finalize the code list and then upload the code list to Data Compass managed by the school. I know there are some other channels that other institutions might use, for example, Calibra. And because the data is already stored in the secure server, server, so we normally can use this data or SAS at the local computer to create variables and select study population to run the codes against the real data directly. And again, we can redact and interpret the results using the same methods. But for OpenSafely, it's slightly different. So let me briefly introduce the OpenSafely Collaborative. It's actually conceived and developed by the Oxford Data Lab and our school electronic health record groups. We developed this OpenSafely Collaborative at the early pandemic 2020, trying to do a lot of COVID-19 research. And we are a team of epidemiologists, software developers, clinicians, and statisticians to develop this new secure analytic data platform. So the central idea of the OpenSafely is that the data never leave the software company, the TPP and EMIS, so as to create a trusted research environment. So for how are we going to work with OpenSafely? Again, we developed the protocol first. It's a very collaborative way using Google Docs, and we make sure the protocol are uploaded to GitHub before analysis. And then again, we developed code list with 2 reviewers, and then we sign off and finalize that using a new web-based code list tool called Open Code List. So actually the public can also use this tool to search the codes and finalize code as well. And because we don't, the researcher never have the access to the real data, so how are we going to test the analytic codes? We actually need to generate dummy data and then test analytic codes using the dummy data. But for us to generate the dummy data, we need to use Python script to generate those dummy data. And here is the example of the Python script that we used. For example, how are we going to define the covariates for asthma alpha? And after the study definition run locally, the dummy data can be automatically generated. And the dummy data of same structure, variable names, variable types as the real data. And you can also define expectation or the range and the prevalence of the diseases using the Python script. And then after we archive and document the analytic codes to GitHub, the codes will be executed on the server remotely to get the aggregate data result outputs back to the GitHub. And we make sure that the results are redacted before we release to the GitHub as well. So very easily, the redacted result can be downloaded from GitHub and it will be ready to publish for peer review. So here is an example of our study using OpenSafely platform to investigate the safety of NSAIDs in the context of COVID-19, and it was published very quickly. So to compare the traditional model and OpenSafely, there are some aspects that we can consider. So in terms of research transparency, using the traditional model is actually quite varied. It really depends on whether the researchers want to publish the code list and analytic codes in appendix or in GitHub. And if they don't use GitHub, it's really difficult to get a structured version control. But for OpenSafely, the workflow enforces both transparency and version control. In terms of flexibility of analyzing the data, using the traditional model, we can test the analytic codes on the real data directly. So it's more flexible to clean and create data sets. For OpenSafely, it's quite rely on existing Python functions for data management. So it's a little bit less flexible. But in terms of data security, using OpenSafely model is very high data security because there is no direct access to real data compared with the traditional model. And in terms of timeliness of data availability, using traditional model could be several months of date using CPLD as an example. But for OpenSafely, it's near real time for primary care data, although it has little minor lags for linked data sets. So lastly, for resources to maintain, using a traditional model, we usually only require a researcher who has skills of Stata RSAS to conduct all analysis. But in OpenSafely platform, if you want to do a new analysis, you require developers and researchers to create new data structures. But it's also less resource intensive if you just to repeat the same steps of data management for different analysis. So we believe that using the new model, we can actually we don't really need to move the data around, and we can make sure to not to compromise the patient record confidentiality. At the same time, can also do the research. Thank you.
So thank you so much for the very interesting new approach. So let me check the chat and Q&A. Don't see any raised hands, I don't think, but I have a couple of questions. First of all, I really like that you started by presenting the UK healthcare system. I think it's very relevant to view those validation studies just like any other real world studies in the context of the healthcare systems that produce them. So the OpenSafely and the Open Codes interface, is it only for codes that are used in the CPRD, or is it with international, a broader collection of codes, and can you actually rely on those algorithms in your studies? In other studies, I should say.
So is your question about whether the codes from the CPLD, sorry, can you repeat your question?
So, sorry for not being clear. So you, I Googled this Open Code Lists website.
Yeah.
Yeah. So, and you reposit those codes that you're validating on that website. So do they come from the CPRD? Are they just read codes, or are they also, let's say, ICD-10 codes? And then once you've validated them, do you maintain a library of algorithms that can be then used by others?
Thank you very much for your question. So the Open Code List tool is actually, you can actually search the codes, the read codes, SNOMED codes, and also ICD-10 codes as well. So basically, they're from the NHS website and other data and other sources. And then for that tool, you can actually document all the keywords that you search. So the search strategy can be very clear, and it should be there in the using the code list tool. So it's actually quite easy, user-friendly to use as well.
And how do you come up with a list of codes to begin with?
Again, it's a very, very good question. I would say because we have a lot of experience using CPRD in OpenSafely team, and I have to say that we actually usually we have a template like how we used the codes before, and then we try to use those keywords to search those codes and make sure the codes that we used before have already included in that codeless builder as well. And again, we also have clinicians to double check the codes to review. So yeah, this is our approach. And we also have another epidemiologist or statistician to sign off finalizing the codes as well.
Thank you. Susanna has a question.
Thank you very much for this great presentation of this exciting resource. I had a couple of questions more about, so when, is it within the same research team or some team within OpenSafely who is responsible? You mentioned that there is code reviewers, that there is someone who redacts results. Does this also apply when other teams work with the data? And also this, it seems like there's an infrastructure. What's the long-term maintenance of the system? Because over the years in some other systems, that's the maintenance of moving this, something that's exciting as this forward is been under discussion. And well, anyway, that's the question. Yeah.
Yes, thank you. So currently, because we're still at the very first beginning of developing this platform, and in the past, only the London School of Hygiene Tropical Medicine Electronic Health Record Group and also the Oxford Data Lab people can redact the data, doing the analytic codes, etc. But then right now we are opening up for collaborations, and because the central idea is that the data never leave TPP or EMIS. So once they write up the analytic codes, and maybe we have other collaborators, we can check on the codes, we can redact. We also make sure the system is at least 2 people have to redact the result before it release back to GitHub as well. So we're opening up collaborations, but it's still an early stage, I would say.
Thank you. There's a question.
Yep. So question is from the audience, in addition to codeless, is your analysis code open? Asking because title says it's an open source analytics platform.
Yes, thank you for your question. So the analytic code is also open for public to review as well, and also it's good for the peer reviewer to review the codes during after we submit the papers to the journal. So they are all of them are on GitHub right now. So once we submit the paper, the GitHub repository can be viewed in public. So you can view all the version control, how we analyze the data, how we write all the analytic codes, they're all there.
Great, it's very good to know. Thank you very much. We don't have any more questions, and we need to move on. Thank you, Angel, for the presentation. Very interesting. Susanna, you're on mute now.
Okay, thank you very much. Our next speaker is Liz Gary from Aetion, and she has back-to-back presentations, and she's asked us to present them this way so that the questions will be all handled at the end of both. The first one is the use of EHR to inform a claims-based algorithm to categorize inpatient COVID-19 severity. And the second is the categorization of COVID-19 severity to determine mortality risk. Over to you, Liz.
Great, and I am sharing the right screen, correct?
Yes, you are.
Wonderful. So thank you, everyone. I'm going to go ahead and get started. Here are our disclosures. Although this work is part of a COVID-19 research collaboration with the FDA, it does reflect the views of the authors and not the FDA's views or policies. I'd like to acknowledge all who contributed. All right, so according to the WHO, there have been over 208 million COVID-19 cases globally and over 4.3 million deaths. In the US, it's well over 36 million cases and over 617,000 deaths. As a respiratory condition, COVID-19 patients may require respiratory support, which includes three types shown in the white box here. They're all various forms of oxygenation, but vary primarily in how they are delivered. So O2 or supplemental oxygen is delivered via loose fitting mask or nasal cannula. NIV or non-invasive ventilation is positive pressure that typically includes other gases with the oxygen and is delivered via a more tightly fitted mask. And IMV or invasive mechanical ventilation is similar to the NIV, but that positive pressure is delivered via intubation, which is obviously far more invasive than just a mask. The IMV can occur with or without additional organ support, which, for example, extracorporeal membrane oxygenation or ECMO. So this is important. Classification of these three categories or respiratory support in general is important, as can be an indicator of degree of disease severity in COVID-19 patients, which is critical for evaluating severe outcomes such as death. So the World Health Organization developed a score to classify COVID-19 severity outcomes that can also be used to determine baseline severity. However, it does rely heavily on the availability of clinical information, such as O2 saturation, for example, that's not always available in real-world data. Another severity score was developed by the FDA Sentinel Initiative to classify severity from asymptomatic to critical. It does use real-world data, but the categories rely on diagnoses being available each day while the patient is hospitalized, which is not always available, especially if the data that you're using relies on discharge summaries, for example, to capture all diagnoses. Given these limitations, there was a clear need for COVID-19 severity grouping algorithm that was applicable and readily available in real-world data, especially in the inpatient setting, which brings us to our first objective. So our first objective was to develop an algorithm for an inpatient score with broad real-world data utility. The second objective was to use electronic health records as an external benchmark to improve upon our initial administrative-based algorithm. Our motivating example that we used compared the effectiveness of dexamethasone, a corticosteroid, versus non-use of a corticosteroid. We expected the IMV or invasive mechanical ventilation to be very well recorded in the administrative real-world data, given both its invasiveness and its costliness. But we had concerns about the O2 or the supplemental oxygen and the NIV procedures, as they may not be as well captured. So in the interest of time, I'm going to start with the conclusions first and then tell you how we got there. So applying learnings from an EHR-based exploration, we were able to improve our administrative algorithm and minimize treatment differential misclassification of COVID-19 severity. Our findings demonstrated the importance of considering additional proxy measurements. And in this example, severity would have been substantially underreported had we relied on procedure-based encounters alone to define respiratory support, specifically the O2 and the NIV groups. And although further validation efforts may be considered, our algorithms that I'm going to present here are an important addition to the COVID-19 literature and have broad applicability for disease categorization, both in EHR and administrative real-world data sources. So how did we get there? We used the Optum de-identified COVID-19 electronic health records to create our EHR cohort, and we used HealthVerity administrative data to create our administrative cohort. Both include diagnoses, procedures, medication use, and lab data. ChargeMaster data from the HealthVerity also provides diagnoses, procedures, and medication detail via administrative hospital billing data. So back to the WHO clinical progression scale, it ranges from uninfected, a score of 0, to dead, a score of 10. The modified version that we developed, which we'll refer to as the MWHO severity score, restricts to the scores that are applicable to hospitalized patients. And as you can see in the 3 red boxes here, excuse me, we took 6 categories and collapsed them into the 3 neither being neither O2 NIV nor IMV, O2 NIV, or IMV. And the IMV is with or without additional organ support, such as ECMO. So in each data source, we defined the two different algorithms. First, we developed a procedure-based algorithm referred to here as the initial algorithm. And it was similar for both data sources, both the EHR and the admin. So then what we did is we expanded the algorithm to additionally include diagnoses that indicated a clinical need for a respiratory support procedure. This was acute respiratory distress syndrome, or ARDS, for IMV, and hypoxia or hypoxemia for the O2 NIV group. We call this the expanded algorithm. For the EHR data only, this also included the use of patient vital data to indicate oxygen support. So in the example, our motivating example, we identified patients that were hospitalized with COVID-19, being either a diagnosis or a positive lab test, and patients had to have at least one medical encounter during the baseline period. No corticosteroids during the 90-day washout. We then selected all dexamethasone initiators, which we'll call Dex Plus, and a random selection of patients who had not yet initiated any corticosteroid of interest. We'll call these the CSI minus patients. And we one-to-one matched them on the date of the Dex initiation and other characteristics, including the MWHO severity score. So the primary analysis cohorts were matched on the MWHO severity score using the initial algorithm. So that's the procedures only algorithm. And we evaluated the distribution of patients in each severity level according to both the initial algorithm, and then we evaluated patients, how they would have been categorized via the expanded algorithm. We also had secondary and sensitivity analyses that are not shown in the interest of time. And all analyses were conducted using the Aetion evidence platform. So getting to the results, here we report results from the primary analysis, and this is among patients in the administrative cohort. So there are two Sankeys here because we report the shifts for each treatment arm separately. You'll notice that the distribution, excuse me, you'll notice that the distribution of each category are the same for the initial algorithm, which is the left side of the Sankey, which is by design since the cohort is matched using that algorithm. Then we took the same cohort and we recategorized them using the expanded algorithm, which is the right side of the Sankey. And we were able to see that there were major shifts and the shifts were differential by treatment arm. Specifically among those categorized initially as neither via the initial algorithm, we saw that the expanded algorithm shifted 54% of the Dex Plus patients and 28% of the CSI minus patients to the O2 NIV group, which is clearly differential by treatment arm. We also saw that the expanded algorithm shifted 2% of the Dex Plus and 1% of the CSI minus from neither all the way up into the invasive mechanical ventilation or IMV group. Among those initially categorized as O2 NIV via the initial algorithm, 7% of Dex and 3% of CSI minus patients shifted up into the IMV group. We also saw similar trends among the EHR-based cohort, which I will not show here in the interest of time. So there are benefits and limitations of the Health Verity administrative data that we took into consideration. Among them, first, open claims do provide near real-time capture, but maybe less complete, especially in more recent dates. However, because our study period ended in August 2020, to align with the EHR data that we had available at the time, this concern was fairly minimal. Next, we used inpatient medication data via the charge master data, which although is a great bonus to have in real world data over many other data sources, it does use non-standardized vendor descriptions rather than standardized NDC codes, for example. So we did have to develop search string algorithms with a licensed pharmacist in order to minimize the potential for misclassification of key medications like the corticosteroid use. And finally, day-level diagnoses were not consistently available in this data source when a patient was hospitalized. However, we did have both admitting diagnoses and discharge diagnoses. And 90% of our cohort were early initiators with treatment that initiated either on or shortly after the admission date. So this concern was also further mitigated. So as I close this first talk, I just want to remind everyone of the conclusions that were previously presented, and I'll move on to the next talk and then open it up for questions. Thank you. All right, so this second talk actually takes that algorithm further to utilize an internal benchmark to look at the categorization of the expanded algorithm and how it's related to mortality outcomes. Here are the disclosures again. I'd like to acknowledge all who contributed. And these next two slides are the same from the last presentation. So in the interest of time, I will just kind of skip through them. We all know that COVID-19 is an active problem. And I'll just quickly note, in case anyone joined, there are 3 types of respiratory support. They're all different forms of oxygen. They vary primarily in how they are delivered. O2 is delivered via loose fitting mask or nasal cannula. NIV, or non-invasive ventilation, is positive pressure that typically includes other gases mixed in with the oxygen, and it's delivered via a more tightly fitted mask. And then IMV, or invasive mechanical ventilation, is similar to the positive pressure of the non-invasive ventilation, but it is delivered invasively through intubation. And that IMV, just as a reminder, can occur with or without additional organ support, such as ECMO. This classification of baseline respiratory support is very important as an indicator of severity and critical for evaluating severe outcomes such as mortality. Okay, so also as mentioned in the last talk, the World Health Organization did develop a score to classify COVID severity. However, it does rely heavily on the availability of clinical information that's not always available in real world data. The FDA Sentinel score was developed for real world data, but the categories rely on diagnoses being available each day when a patient is hospitalized. So given these limitations, our team developed a modified WHO score, the MWHO score, which was described in the last presentation. And this classifies patients into the 3 categories of neither O2 nor IMV, O2 NIV, and IMV. The algorithm includes both procedure-based encounters as well as diagnoses indicating the clinical need for a procedure. And again, this was hypoxia or hypoxemia for the O2 NIV group and diagnosis of acute respiratory distress syndrome for the IMV group. But as a newly developed algorithm, its utility still remained to be further explored. So that's what the goal of this presentation is. So we had 2 objectives. The first was to estimate mortality risk and mortality rate in a cohort of patients hospitalized for COVID-19, stratified by the 3 MWHO subgroups. Second, we attempted to demonstrate that patients with greater disease severity categorization upon admission were at higher risk for mortality in order to further establish the utility of this algorithm, especially for use in confounding control. And we expected that increasing levels of COVID-19 severity were associated with an increased risk and rate of mortality. So again, I'm going to put the cart before the horse and present the conclusions first and then circle back how we got there. We did observe a positive association, as we expected, between the MWHO algorithm defined severity, and that was the severity at hospital admission, and both mortality risk and mortality rate. Although the performance of this algorithm to identify each severity level upon hospital admission does remain to be further validated, this does indicate confidence in the use of this algorithm to categorize severity levels for confounding control, to categorize subgroups in treatment effectiveness studies, utilizing real-world data sources. Okay, so here the data source that we used was the HealthVerity administrative data. This includes diagnoses and procedures via open and closed medical claims, and also ChargeMaster hospital billing data. Unlike most real-world data sources that only have outpatient pharmacy claims for medication use, the ChargeMaster data also provides medication details while a patient is hospitalized. We also had lab data with results for SARS-CoV-2 or COVID-19 tests. So the study cohort included patients hospitalized with confirmed COVID, so that was a diagnosis or a positive or presumed positive test, with an admission date between April 2020 and February 2021. We excluded patients if they had either no medical encounter via claim or ChargeMaster during the 183-day baseline period, or if they were missing age, sex, or geographic region. Most covariates were assessed either over the 183-day baseline period or upon admission for demographic criteria. Patients were stratified into subgroups according to the 3 MWHO severity categories upon admission using the real-world data algorithm that we previously presented. So the primary outcome of all-cause mortality was defined as an inpatient ChargeMaster encounter with a discharge status of expired. Although death data confirming date of death was not available for patient privacy concerns, we did have death data with month of death available to confirm that patients with a discharge status of expired did indeed also have a corresponding record of month of death. Follow-up to ascertain 28-day mortality began on hospital admission date and continued until the occurrence of the outcome, hospital discharge, or 28 days after admission. So this study reports descriptive statistics for patient characteristics determined a priori and mortality risks and mortality rates. This was done overall and for each MWHO subgroup. Then we evaluated trends for heterogeneity using a Cochrane-Armitage test for the risks and a log rank test for the rates, while analyses were conducted using the Aetion evidence platform. We conducted also, among other sensitivity analyses, the two that we'll show to evaluate the robustness of our findings are first, we evaluated mortality risk and rate using 5 more granular severity groups that more closely resembled those of the MWHO progression scale. So here we present, we looked at neither, which is the same as ours. We then split the O2 NIV into 2 separate categories, and we split IMV with and without additional organ support into 2 separate categories. The second sensitivity analysis aimed to confirm the utility of the algorithm even during the early months when the pandemic, when the disease landscape was still rapidly evolving. So that analysis limited to data April through August of 2020. So moving on to the results, this yielded a mortality risk of 11.8% overall, which increased with severity as expected from 3.4 for the neither group to 47.3 for the IMV group, which is the highest. There was a significant trend for heterogeneity, which can be seen here, both by the non-overlap of the confidence intervals, but also via the P for trend that is less than 0.001. Similarly, the mortality incidence rate of 15.11 per 1,000 person days, that was the overall rate, and it also similarly increased with severity from neither to IMV. And again, had a significant trend, and none of the confidence intervals overlapped. So here is the plotted cumulative incidence cumulative incidence of mortality with the 95% confidence intervals. It is hard to see the confidence intervals because they are so tight, but they are technically in the lighter colors here displayed. It's also stratified by the 3 severity groups, and you can see that there's a clear divergence that started early and it held over the follow-up period. In the first sensitivity analysis, the increasing trend remained among the more granular subgroups. So we still had significant differences in all 5 of the subgroups. In the second sensitivity analysis, the increasing trend remained even during the early months of the pandemic. So as I close here for questions, I want to remind everyone of the conclusions that were previously presented. Thank you so much.
Thank you very much, Liz, for the 2 very interesting and relevant presentations. We already have questions. So I'm going to start with the Q&A chat. So there's a question from Kevin Haynes, and since let me read it out loud. Does the Health Verity data have enrollment information? If yes, why would you need to require the presence of an encounter in a baseline period? You will miss healthy people happily enrolled in a health plan with no encounters but index COVID. How does Health Verity get claims data since they're not an insurance company?
So that's a great question. So the first answer is no, there is no quote unquote enrollment field in the Health Verity data, which, you know, as someone that is used to working with claims data like, you know, MarketScan and Optum, which have that enrollment variable that we typically rely on, it was something that we had to kind of think a little bit more outside the box about. There's no concept of enrollment because we have both open and closed claims. So closed claims have this concept of enrollment, whereas open claims have a broader variety of the types of patients. And so this is really a proxy that we required they have at least 1 medical encounter during their 183-day baseline period to guarantee that we can at least identify some of their covariates. We, in some of our additional analyses, we further explored looking further back a full year to make sure that they had an encounter in a year instead of just a 183-day baseline period. And we did find similar estimates. And I agree that the reason that we did look also a full year back is because healthier patients prior to their COVID experience that may not go to the doctor, you know, within 6 months, but, you know, would go annually, are more likely to be captured with a 1-year look back. The other thing to take into consideration though is the way that we defined our, which I didn't fully get into here, but the way that we defined our COVID diagnosis criteria, they were allowed to have diagnosis or positive test, not only during the admission, but within the 21 days prior. And so some of these patients might have been diagnosed in an outpatient setting within the 2 or 3 weeks prior to hospitalization when they were a more minor case, and then later got hospitalized. And so the thought is that we would have a decent medical history on them, but it is of course a limitation that we don't have enrollment. Hopefully, does that answer your question?
There is no, I assume so.
Okay.
There is a question from Sasha Dublin. Sasha?
Thank you. So if I understand right, you're using diagnosis codes or diagnoses, and you're calling it the HR of ARDS or hypoxemia as indicators, and that's kind of assuming that an ARDS diagnosis would lead to invasive mechanical ventilation, or
Yes.
that hypoxemia would lead to oxygen therapy. But I actually think those are really problematic assumptions based on some experience. We were collaborating with people using MarketScan data, and they used a cohort with ARDS, and they found that only 16% of them had codes for invasive mechanical ventilation, demonstrating that either there's a big problem with sensitivity of IMV or that ARDS is being used to identify a condition not needing ventilation yet. And I think it's just really problematic. If you want to use these diagnoses and put them in a propensity score, I think that would make sense, but to sort of assume they're proxies for a treatment doesn't meet clinical scrutiny. And I think the other thing I want to point out is that in reviewing a bunch of charts, at least in the Pacific Northwest, we're using a lot of high flow oxygen by nasal cannula, and we're using almost no CPAP or BiPAP. And so I think that within your nasal cannula oxygenation category, we're going to really have to learn how to distinguish just plain old nasal cannula from high flow nasal cannula, because it's a huge difference as a severity marker. I guess I would just put in a plea for if there's any way to test your algorithm and try to validate it where you can actually review the medical records and read the clinical notes. I think that, I don't think you can really conclude that your algorithm is minimizing treatment differential. You can prove that you can move people from category to category, but you really need a gold standard that's based on a kind of a true proof of what they actually received.
Yeah, and that is completely fair. And I just want to answer that with two comments. And the first is that, we completely recognize that this algorithm remains to be further validated, which is here on the slide. And we hope to have that opportunity. However, in the interim, these are explorations that are, attempting to test I shouldn't say test, but to measure our algorithm against both internal and external benchmarks. Because internal and external benchmarks are a great way to start to further understand how these algorithms are operating. And external being the additional data source, the electronic health records, and internal being looking at the death outcomes. The second point that I wanted to make is that we didn't just come up with this. This was in collaboration with clinicians who had said that in their experience that the majority of patients with ARDS would be initiated on invasive mechanical ventilation. And similarly, that the majority of patients with hypoxia or hypoxemia would be initiated on oxygen support. So that was kind of the premise that we based a lot of these decisions on. But again, I completely agree that further this algorithm does remain to be further validated, and it is something that we hope to be able to do in the future. But as you mentioned, I think in your talk, there are a lot of resourcing constraints, and it is a challenge to identify that gold standard in order to further validate these types of algorithms.
Thank you. There are two more questions, and I think maybe a short answer to each. So one is, how would you recommend to use or adapt your algorithm to account for change in severity over the time during the hospital stay?
Yeah, and that's a fair point, and it is something that should be further considered. This was just, again, an initial exploration looking at admission severity and longer term outcomes. But for example, we have looked at severity at time of treatment initiation and outcomes as well. And so there are a lot of different changes in severity to take into consideration during the hospital admission.
Thank you. And the last question is, what about deaths after discharge, but within 28 days of admission? Could those occur in the hospice care or in nursing home? I guess the question is,
so the short answer is yes, but the longer answer is that we did not have access to full mortality data. What we had in order to determine date of death was our inpatient data. And so we didn't have confidence in what happened to the patient after they left the medical inpatient setting. And so that's why we did censor upon discharge.
Thank you, Liz, very much for your
Thank you.
presentations.
Okay, thank you very much indeed. And it's my pleasure to introduce the last speaker of this session, Ron Herrings from Pharma Institute, who will present on the development and validation of an algorithm to estimate the risk of severe complications of COVID-19 to prioritize vaccination. Over to you, Ron. You're on mute. You're on mute.
Okay, I'm sorry.
Now it's okay.
You probably see my slides.
Yes, and it seems like you're about to start presentation mode, and it works well. Thank you.
Thank you very much for giving me the floor. And I start actually first with to mention that I'm sitting in the dark. I miss some light over here, but that will not be a problem, I hope. I will start to talk about two things actually. The first of to develop an algorithm, which is called SCOVID, to estimate the risk of hospitalization and death complications of COVID-19 infections and how we use this to prioritize vaccinations. This is my team, which is presented on the first slide, who did this, and it started off working in March 2020. The study was funded by a couple of organizations which are in charge of the IT system, which are used by the Dutch GPs. So we had actually no funding, but it started off as a couple of friends, organizations who were aware of the panic which started in March, April 2020. It's good to refer to that we in the Netherlands are with 17 million people, and that we have 85 hospitals and a total of only 2,000 intensive care unit beds. So you can imagine that if in the beginning of the epidemic, of the pandemic, the risk of hospitalization of people with infection was estimated at 10%, and of those who are hospitalized, it was estimated that 10% did go to the ICU, which would actually mean that with 200,000 infected patients, we would run into code black. We would run out of capacities in the hospital. So in that situation, we try to help to develop an algorithm to estimate the risk of hospitalization or deaths due to COVID virus infections. And why we needed that algorithm, that was actually to see whether we have to shield particular patients with high risk from infection, to prioritize early treatment at home, to prevent that they were hospitalized, and last but not least, to prevent actually to prioritize patients for vaccination. And that was used to explore different vaccination scenarios. So we started off with thinking from how we could actually have data, because in such situation where we started, there were actually no measures, no distancing, no test, no codes for the test, and no codes for COVID was available in the electronic health records. And also not very good data because they were too late. Data are collected once a month or once in 3 months or once a year, depending on the GP. But we could have particular information about potential predictors, which was mentioned by the National Institute of Health in the Netherlands. And these included at that time age, sex, BMI, also whether the patient had a test, yes or no, which was not quite obvious in that time. Chronic comorbidities, and they listed about 15 of them, including, for instance, diabetes and cancer. There was some evidence already from the United States and from England that the neighborhood deprivation score could be a very good proxy for it. And we also had a time period in which in the first time period, there was actually no measures. And it started in time to include in society all kinds of measures, which is very difficult for studies where you want to assess the risk, because you have a kind of depletion of susceptibles in your database, that patients who become aware of, people become aware more and more that they might are at risk, and they shield themselves from infections. So what we actually did is that we asked the IT companies in the Netherlands, which about 17, to help us to put a GP questionnaire in their system so that we could day by day collect for every GP information about patients who have COVID. And we asked actually the doctor to fill in the questionnaire, whether the patient had COVID, how he know that the patient had COVID, what the lag time was of the diagnosis, whether he was dead, whether he was hospitalized, etc. And we also asked an informed consent of the patient and the GP to link these data to the electronic health record of our system. These data were used for a prediction algorithm for which we used a lasso regression analysis to select a limited number of predictors. We wanted to have a simple algorithm. And secondly, to estimate and shrink regression coefficients, because there is, of course, a lot of interaction between all these different risk factors. For instance, people with a high BMI are most likely to have also more risk to develop cardiovascular disease, and you cannot put them into one regression model without without shrinking of the regression coefficients. We actually split a data set in two pieces, one of 70 in which we trained an algorithm, and a validation set. And it's actually a living algorithm. It was produced or measured in such a way that every day when there were no new data coming in, that the algorithm could update the predictors. We of course measured the model performance and the discrimination, and the outcome of the algorithm is a probability that patients develop severe complications if they are infected with COVID. We use this for a scenario simulation. So what we actually did is that we, for each patient in a GP practice, calculate based on his comorbidity the probability that if he would be affected, that he would be hospitalized for COVID. If you summarize these probabilities, you have the total number or an estimate of the total number per GP practice that if everybody would be infected, would go to the hospital. So what you do now with these estimates is you can make a ranking by GP, those who have the highest risk and the lowest risk. And the faster you can vaccinate actually, and you start with those with the highest risk, the best performance you have in preventing patients from being hospitalized or die. The effect, what we actually studied of the different scenario, was estimated because there was a lot of discussion how we start with vaccination. Everybody or everybody in the working age or only the elderly, who should we vaccinate first? And what we did is that we actually choose 300 selected GPs from the Netherlands. They were about 8% of the total Dutch populations, where we run these different scenarios and estimated what is the vaccination degree we need to have a 50% reduction of hospitalizations. And the scenario models, what we actually did is that if you have such a ranking and you assume that if you vaccinate a patient that the risk goes to 0, you summarize these new, then you can estimate the percentage reduction. So, and you can do this vaccination hypothetically in different ways. You start actually with those with the highest risk first, and you work down lower in risk. We had also in GP practice a label for flu in vaccination. It was suggested in the Netherlands that if you selected people who have an indication for flu vaccination, that would be the patient at highest risk for complications of COVID. You can do the APE scenario. We also use that. That's called just randomly apply some random vaccines to random people. What APEs could do. We had a health council scenario, which actually there was the official scenario in the Netherlands that we start to vaccinate with people from 100, go down to 90, 98, 97, until 65. We had a working class scenario, that is that we randomly actually want to vaccinate people between 25 and 65. It was especially advocated by the economic people in the Netherlands. And we have an old first scenario, which was we only start vaccinations with people above 60. It should be mentioned that in this complete period where we collected these data, we still had no vaccine yet available. That only happened in February 2021. The data setting, what we can actually do, the GPs were voluntarily reporting actually the COVID patients, and we collected the data from April 1st. So it took us 1 month to devise the system, and we had to collect about 7 months of information to have enough practices that reported about 6,074 COVID patients, of which 243 developed their complications. What we actually saw is that if you plotted on the age, is that the highest and the most important risk factors, and you will virtually find it everywhere and in any publication, is age. And we can see that the people of 60 to 60, what is it? Sorry, I missed my glasses. People from 60 to 69 years of age is at 8.9% risk of complication, 70, 79, 72%, up to a 38, about 40% of patients above 90, that if they get COVID, that they are hospitalized or die. The algorithm, and for sake of time, I cannot go too deep into the algorithm, but the algorithm, which is actually selected by the lasso regression, was quite simple and included only a couple of variables. The most important one, you cannot see it, is actually age. Also male gender. Male gender is actually the same risk increase as having one chronic disease, which is the lowest one at 0.1. We have actually what's most important, one of the most important variables is actually the differences in the period before and after the shielding actions we had in the Netherlands. That was after July 2020, we started to wear mouth caps, and we had these 1.5 meter distancing measures. Obesity was actually, because the models, a lasso model runs about 100 or 150 times. Obesity was excluded from the model. What's very important is that you really need a positive test to be sure that the patient has COVID. And of course, that was not in the beginning of the data collection, but emerged in time that we have testings. And people in the low social deprived areas had a much more increased risk of developing complications. The most typical one was, of course, patients who have a chronic comorbidity. That chronic comorbidity you can find in our manuscript, which is published on the internet. And you can find that these are cancer, diabetes, cardiovascular disease, lung disease, neurological disease. None of them typically was at the highest risk. But if you have 1, 2, or 3, or 4, then you can add that to your prediction model. It's also the accuracy was very high. There was an area under the curve of 0.91. It was quite precise. And we applied that model to work out the different scenarios. So what you see over here is on the x-axis, the vaccination coverage. This is hypothetically, so about when we vaccinate 10% of all patients. Then you can see that about, if you apply this COVID model, which is the blue line, it's the left line, that about the reduction would yield a reduction of the hospitalization with 50%. That was equal in effective as the Health Council scenario, which is actually the wet one. And that is 100, 99, 98, 97 years of age. This COVID algorithm was a little bit better. The oldest first, you need a 20% coverage to have that 50% reductions. On influenza vaccine scenario, you need about 30% coverage of the vaccination. And the blue one, the ape one, is of course the diagonal. And that's because it's 50% reduction, gives also 50% of the vaccination. With the vaccination degree of 50%, you have a 50% reduction. So if you compare these scenarios, you can see that we could be very effective in a GP practice, that if we only choose the 175 patients with the highest risk, that's about 8.54% of a normal Dutch GP practice, that we could have reduced the number of hospitalization with at least 50%. The same we could actually do with the oldest first, which is the Health Council scenario. So you work down from 100 to 1990 until 65. Then after 10% of patients you vaccinate in the GP practice, about 210 would be 1.7 million vaccinations. You had a 50% reductions, and all other of the scenarios were less effective. And of course, to prioritize people in the working class would be not very effective. You need about 11.5 million people to vaccinate, about 70% of the population to do that, to have that 50% reduction. So risk-based vaccination should be always at highest priority in every country to prevent people to die or prevent people to be hospitalized. So what were the limitations of this study? Well, first, the absolute risk are biased because it's very difficult to assess the absolute risk of hospitalization and deaths in a society where constantly measures are taken that people are shielded or are not going into the risk domain. Secondly, there was an underreporting by the GPs. They did not report every patient. We do not know why they did not do that, but that was because of the chaos of they were too busy. And most likely it was a little bit of an overpresentation of the more severe cases which were reported by the GP. We also had a limited number of patients, so that limited actually the percentage of complications. We had low numbers and we could not do at that time estimates for specific diseases. We now have 5 times more data, but we could not use this for this presentation. So the implication is actually that COVID scenario, so a risk-based COVID scenario, performs best with a consecutive age-based scenario. However, none of these vaccination scenarios followed in current practice. It was a big chaos of all kinds of political and business-wise decisions which took place over the time. And subsequently, we probably have not prevented as much patient from death and hospitalization as we could. We should follow these risk-based vaccination to prevent hospitalization and death because we want to prevent harm by non-vaccination. And the slower the rollout of the vaccination, the more hospitalizations and deaths. For instance, the idea that the AstraZeneca...
We only have 2 minutes left, sorry, Ron.
Yeah, well, it's my last. The idea that the AstraZeneca vaccine could cause adverse drug reaction postponed vaccination for more than a month in the Netherlands. So this implementation of vaccination strategies should be data-driven, personalized to prevent harm, and based on risk mitigation plans. Thank you. I have actually, you can find the complete publications on the internet. If you want to see a movie, a better movie than my presentation, you can find it on YouTube.
Thank you very much. We have about 1 minute for a brief question and answer. And if somebody, actually you answered the one that I had, which was how was this implemented? Okay. I don't see any questions from the panelists or from the chat, from the Q&A. It's been really exciting to moderate this session. I've learned a lot. I hope you have too from these incredible efforts. It really feels we're a hardworking community, no matter whether it is winter or fall or holidays or regular period. Want to thank our presenters, Ron, Liz, Angel, Ajit, and Sasha, my co-moderator Vera, and the ISPE support, and the 100+ participants who have stayed throughout the session. I wish everyone a good rest of the day for the conference, those who stay, and those who are in time zones where we should be already having dinner and going to bed, a restful evening for a new day tomorrow. Thank you very much.
Thank you, everyone. Bye-bye.